because this pain can be quite severe and disabling for the patient. As with any treatment, start with the non-surgical ones, least invasive, conservative measures, and then build up your treatments depending on the response and the ongoing issues. Conservative measures, needless to say, I think we need to avoid prolonged sitting. They say try to not sit for more than 2 hours. If the job involves sitting, then standing desks have been recommended. And when they sit, the position of the knees should be lower than the hip, and that will relieve the pressure on the ischial tuberosity and the nerve to some extent. And using these donut pillows or horseshoe pillows can be helpful because that will specifically reduce the pressure on these areas. Pelvic floor physical therapy can address both the muscles as well as the nerves to ensure that the muscles are relaxed and stretched, as well as the nerve gliding exercises that can gradually stretch the nerve. Medications, all the neuropathic painkillers, try non-opioids first and opioids if required. The adjunctive therapies can also be helpful, TENS machine or CVT. So all these are tried, and in case the symptoms still continue, despite that, we go in for interventional measures, pudendal nerve block being one of them, and that is quite an effective thing. And along with that, you can combine Botox if you find that the pelvic muscles are quite tense as well. This is just to illustrate different ways of doing the pudendal block, transvaginal or transperineal. And the important thing is, of course, we can palpate the ischial tuberosity, and then we palpate the ischial spine. And the nerve is related to just below the ischial spine. And that's where we should be directing the block. A transgluteal block has also been done under guidance. But as surgeons, colorectal surgeons, it's more the transperineal that we'll be doing, and the gynecologists do a transvaginal block. And if all these fail, then of course we think of surgical options, which is basically decompression surgery. It's important that we have appropriate counseling and consenting prior to doing this, because not always these are successful, or they can have their own issues. There are several approaches: transgluteal, transperineal, transhysterectal, laparoscopic, robotic, and even endoscopic through the transperineal route. Along with the decompression, sometimes nerve stimulators are also inserted.
Hello.
Because there's a small
Hello,
role
Dr. Dipali. We are starting OT1, Dr. Pradeep Sharma sir's case, Pilonidal Sinus.
Okay, sir. Okay, sir.
Yeah.
I think he just needs 1 minute.
So we will conclude this session here. And
No, let him finish. Give him
we
1
will-
minute.
Yes, sir. Yes, sir. We will conclude the session within 2 minutes, and then we will start the OT, sir. Thank you, sir.
So this is just to illustrate as to how the transgluteal approach is done. You can see it's a bit of an invasive procedure. You have to divide the sacrotuberous to get access and then free the nerve. And for the images on the left side are the robotic and laparoscopic views, just to illustrate how you can get a magnified, very clear view, and with this minimally invasive. On the right side, that's in the middle, you have what we call the Istanbul technique, where we actually wrap the nerve with fat or omentum, and that has shown to reduce the chance of recurrence or further problems. And on the right, extreme right, you have the wires as well being inserted at the same time for neurostimulation later on. Lower down is where they use an endoscope through this to convert a blind procedure into a more visually improved procedure. Overall, the summary is that if you want more visualization, you need to have a more invasive procedure. That was the feeling. And sometimes when it's more invasive, that can have its own problems of instability in the area. But the last thing, the laparoscopic and robotic approaches, they combine good visualization and being minimally invasive, which is why I feel forwards is that.
Dr. Dipali?
And then
Yes, sir. Just a moment, sir. We are concluding the session, sir.
Okay.
Just a moment.
Dr. Pradeep sir and Dr. Kamal sir both are ready with the OT, and they are
Okay,
waiting for just transmission, and they want to explain some markings, and that's why.
Yes, yes, sir.
Yeah, please do fast.
Okay, some of these have been tried, cryofibrillation and fat grafting. In terms of prognosis, the longer it's been there, the worse it is because there's central sensitization. Younger patients, better response. Nerve blocks, very good, but it lasts for 30 days. So you combine that sometimes with radio frequency, which can increase it. Surgical decompression is good, but laparoscopic decompression has very good response in meta-analysis, both European studies and Brazilian studies. But there's a 16% complication rate, which I think will go down once people do it more often. Recent advances, as I said, robotic and sort of pulse radio frequency have probably a good future role. This is just the take-home message, which is a summary of what we said. And we need to be aware about this condition, think about it, think about non-risk criteria and all the risk factors for that. Initial management is conservative, but there is a role for surgical decompression.
Thank you so much, sir.
Thank you.
Apology to
That's
hurry you
not at all.
up, sir, but we have two OTs lined up and
Absolutely.
both of them are under anesthesia.
We are describing case
Thank
1.
you so much, sir.
Dipali, we are describing case 1 of pilonidal sinus,
Yes,
41-year-old male patient with pilonidal sinus with abscess and complaint is swelling and pain in the natal cleft. Dr. Pradeep Sharma sir is operating that case. He will explain the marking and next. The audio to Dr. Pradeep Sharma sir.
अच्छा एक प्रोब आपो
Thank you so much, sir. We would like to call the moderators upon the dais.
okay
Dr.
so
Parvesh Sheikh, sir, Dr. Rajiv Sharda, sir, Dr. Pawan Agarwal, sir, and Dr. Kaushik Gajjar, sir. Please do the honors, sir.
yeah hello Dr. Parvez, good morning and good morning to all the audience. I think it is before 12 o'clock. Yeah, so good morning everybody. And are you able to see my patient?
Yes, sir. We are.
Yeah.
So, the patient is visible. You are audible, sir.
Yeah.
All the moderators are taking the chair.
Right.
And we are eagerly waiting for the case, sir. Thank you
Right.
so
So
much.
I have put the marking. You can see that I have written head over here. Okay. So that means that this is the head end of the patient. This is the tail end of the patient. This is the right side and this is the left side. The patient is in prone position. So this is for the audience to get an orientation to how the disease is. Now if you can see, yesterday I said in my lecture that every pilonidal sinus starts with a midline pit. Okay, so midline pit, you can see the midline pit over here. This midline pit is the main culprit of a pilonidal sinus. The problem starts over here. It goes and forms an abscess, and wherever the abscess ruptures or wherever the abscess is incised, that forms a secondary opening. So here one can see a primary pit over here, and what you are seeing is a secondary pit over here. I had already put in methylene blue to delineate it. Initially my methylene blue did not go inside, so I gently probed from the external pit, and when I probed it, the debris got dislodged, and now when I am going to put the methylene blue, you will see that my methylene blue comes out from the primary pit. So that means that there is a connection between these two. I will just demonstrate. You saw the methylene blue coming out?
Yeah, we can see that.
Yeah. Okay. Now the pathology in pilonidal sinus is there is a pit, there is a tract, and at the end of the tract there is an abscess cavity. Here the abscess cavity is already ruptured into a secondary opening. So tackling all these elements of a pilonidal sinus is very, very important. Many people forget to tackle the primary pit. They concentrate only on the secondary pit, and that's the reason, a commonest reason for recurrence. The second commonest reason for recurrence in pilonidal sinus is absence of tackling the or failure to tackle the abscess cavity. So if you tackle the abscess cavity, if you tackle the tract, if you tackle the primary pit, I think you will have a good success rate in the surgery of pilonidal sinus. Now here you see that it's predominantly a midline disease. The primary pit is in the midline, the secondary pit is just by the side of the midline. So being a midline disease, being an early disease, I am going to do a MIS technique, minimally invasive technique, plus this is also the first surgery for this patient. He is a virgin case, so this is the first surgery for the patient. So I am not much in favor of doing an extensive flap. I do lot of flaps, but all my flaps I reserve for complicated cases, for complex cases, and recurrent and re-recurrent pilonidal sinus. For a de novo pilonidal sinus, flap is not the answer. Minimally invasive techniques should be applied, and they are successful in about 70 to 80% of the patient. Now what I am going to do, I am going to probe this, and if you see, my probe is coming out from the secondary opening. So this is how my track is. So the first thing what I am going to do is that I am going to excise both the openings, the primary pit and the secondary pit, and then I have already marked the length of the scale. I have already marked the length of the track. The track I have marked it, it comes to around 3.5 centimeter, which I have written over here. Now why do we measure the track? We measure the track because just like fistula, we have to deliver that much amount of energy to the track, roughly about 100 joules per centimeter. So this is about 3.5, so I cannot go beyond 350 joules. Okay, so that is why measuring the track is equally important. I'll be setting the laser energy at about 10 watts. I'm going to use a radial fiber or a corona fiber, the way we use for a fistula track. So the first thing I'm going to demonstrate is a Gibbs technique, or the punch excision of the pit. So first, sister, you give me about 5 millimeter punch, 5 millimeter punch, green one. So the secondary opening is always little bigger. So you have to use, can you see this punch?
Yeah, we can see that.
Okay. So these punches, they come in various dimensions, right from 2 millimeter to 10 millimeter. Choose a size of punch which is slightly bigger than the size of the pit. Now here the pit seems to be roughly about 3 or 4 millimeter. So I am going to use a 5 millimeter pit. Now when you excise the pit, there are many ways of excising the pit. Usually when the dermatologists, they use a punch, they put it perpendicular to the skin. But we are not going to do any dermatological procedure or a skin biopsy, etc. We are going to excise the pit. So the direction of the punch has to be along the direction of the pit or the direction of the track. So you have to feed it, or you have to railroad it over the probe. Okay, so this is how I am going to excise the secondary pit. Are you able to see it?
Yes.
Yeah. So with rotatory movement, I am going to excise the secondary pit. So I have excised the secondary pit. I am going to keep it like that only, and I am going to now use the other punch. Now you can give me, sister, about 3 millimeter or 2 millimeter punch. So this primary pit is little smaller. So again I am going to railroad it over this, and I am going to excise the, with rotatory movement, I am going to excise the primary pit. Okay, so once I have done that, I am going to use a hemostat. Give me an artery forceps, and I am going to remove the tissue which I have excised. Gauze piece, a small gauze piece. So you will see that all this methylene blue colored tissue is going to come out. So this contains the epithelialized tract, this will contain the hair, and this will contain all the keratin and the unhealthy granulation. And then I am going to remove the
Sir, we'll just briefly shift the audio to OT2 as well, as we are also waiting for a while.
Yes, yes, sure.
Please shift the audio to OT2.
You can, because now I am just going to take some time to clean this track. That's all.
Meantime, can I ask one question to Dr. Pradeep, sir?
Yes.
So Vijay Shivpuje here.
Yes.
Sir, can we do BASCOM procedure in this case?
BASCOM I will show in the other case. BASCOM I don't want to do it in a case which is a de novo case. So here I will always...
I'm talking of simple...
All questions to be addressed to the moderator. The moderator will ask the question.
Patient has been taken on the second OT.
Yes, please, let's just ask Pradeep sir after some time. Please shift the audio to OT2.
It's a request for all audience. Any question to be directed only to the moderators here, nothing to be asked directly to
A
the
57-year-old
people.
male, MRD number 272063, diagnosed with grade 3 hemorrhoids at 11 o'clock, with the complaints of something coming out per rectum since 6 months with pain during defecation. On examination, grade 3 hemorrhoids at 11 o'clock and grade 2 at 3 and 7 o'clock. On investigations, all reports within normal limits. The surgery is to be performed by Dr. Kamal Gupta.
Yeah, good morning, everybody. Are we with you? Prajesh, am I
Yes,
with you?
Kamal, we can hear you.
Okay.
What are you planning for this patient?
Yeah, Pravesh sir, very good morning to you. Pravesh sir, the patient has got grade 2 hemorrhoids at 3 and 7 o'clock and grade 3 at 11 o'clock. So what I propose, I will like to go for finger-guided hemorrhoidal artery ligation with laser hemorrhoidoplasty at all the 3 places, and in case it is required, at 11 o'clock, I will go for rectoanal repair or Blaisdell. That is mucopexy or Blaisdell. And as Prajesh has pointed out, I will be just narrating all the steps, but I will not be answering any questions. I have got a moderator with me. Dr. Maheshwari is there. So all the questions can be directed to him. And once I finish the case, only after that I will start answering the questions.
Okay.
So this is the first step. This is Park's maneuver. Now you take 3 gauze pieces, roll them, and take them inside. Gradually bring them outside to assess the degree of hemorrhoids or the degree of prolapse. So you can make out the mucosa prolapse is there at 11 o'clock position.
Yeah, we can see that 11 o'clock pile prolapse.
Yeah, so that is there. So I will take a half-cut proctoscope. Jelly, please. Alice. 20 vicryl. ये पकड़ना पड़ेगा किसी को ना आप आगे आ जाइए प्लीज.
Kamal, you can just talk a little about your finger-guided ligation that you are doing.
Yes, so that is what I'm going to start. So the first step which I'm going to do is palpate the vessels. Now these are the pile masses, and one thing I would like to share with the audience, that never expect the hemorrhoidal artery branch is going to be at 3 o'clock, because the position of the rectal arteries is not constant. So I am just palpating. It is there. It is around please आराम से छोड़ दीजिए इसको ना, आप पकड़िए. It is around 2.5 o'clock position, not 3 o'clock. So I will take a stitch now. So the thread which I am using is this is 26 mm 5/8 needle. So normally I use 27. And just this is a dentate line. I want everybody to appreciate the dentate line. This is a dentate line. And
no, your head is coming in the way. The cameraman can just go to the side. He can shift to your left actually.
Yeah, I think cameraman is adjusting.
Yeah.
थोड़ा सा ना
So
अंदर
which
light
suture
आ
do
रही है,
you use,
please.
Kamal? Which suture you said you use?
Light is not inside actually.
Yeah. Probably there's a cord light which can show inside. So can you describe at what level are you going to take this suture?
Sir, I will be taking a stitch 2 to 4 centimeter above the dentate line.
Okay. 2 to 4 centimeter proximal to the dentate line. And what number vicryl is this?
So the whole purpose is to go 2 to 4 centimeter above the dentate line, is that once you are 2 to 4 centimeter above that, the depth of the vessels is 3 to 5 millimeter, and it is very easy to palpate the vessel and take a bite. थोड़ा सा ऊपर करके रखिए please, ऐसे ना, ऐसे.
So you're taking a bite in the submucosa, right?
No, I am taking mucosa, submucosa, and the fibers of the internal anal sphincter. Give me another.
So your needle is going through the internal sphincter.
And Professor, I will not be able to answer all the questions as per NMC guidelines, but definitely I can demonstrate.
So, Dr. Maheshwari can answer that question.
Dr. Maheshwari, you can answer on my behalf. I am taking the stitch that is थोड़ा सा इसको ना खींच के ठीक कर लो आप इसको पकड़ लीजिए 2 to 4 centimeter above, taking mucosa, submucosa, and this is a figure of 8 stitch which I am taking. This is based on vascular surgery principle. If you want to occlude a vessel, the surrounding tissue should always be taken. So all of us as surgeons are very well aware of that. And I always use 2 needle holders. Where is my needle now? Just hold it. So that is a figure of 8 stitch. Now I will ask my assistant to go for milking. इसको ना ऐसे ऐसे press कीजिए, press कीजिए. नहीं आप कीजिए. So this will lead to disengorgement, and then I will take a knot. छोड़ दीजिए please. Now once I have taken a knot, again I would like to palpate. No, now I am not able to palpate. It means I have taken a stitch deep enough to encircle the vessel.
How do you compare DGHAL with finger guided ligation?
Doppler guided, actually FG Hall is based on the principle of DG Hall, because when somebody taught me how to do internal opening on DRE, how to find it, so next thing which clicked was, can I replace Doppler guided with FG Hall? If my finger can find internal opening, why can't I palpate the vessels? And since last I think almost 10 years now, the results are at par. Now there are nice guidelines which have very clearly demonstrated that.
As I understand, you are going to ligate all the vessels first and then you will do the laser.
Yes, sir. The principle is.
So can we go in the meantime audio to Pradeep's side? I think he's waiting for the next step. We'll come back to you, Kamal.
So
can we shift the audio to Dr. Pradeep Sharma?
This is an additional vessel which is palpable at around 6 o'clock. And it's a wrong notion to say there are only 3 vessels.
So basically, whatever pulsations you are feeling, you're going to ligate those vessels.
Yeah, I will be ligating all the vessels, but I will not be doing laser hemorrhoidoplasty at these places. Laser I will do only at the places where hemorrhoids are present.
Okay. Fine. Can we go to Pradeep? Can we go to the other OT, please? The audio. Can we shift the audio to the other OT?
Please shift the audio to OT1.
Gauze piece, please.
Is there somebody there from the audiovisual side listening? Audio बीजा OT ऊपर shift करो.
इसको ठीक क्लियर कर लीजिए. इसको छोड़ दीजिए, please.
Please shift the audio to OT1. The technical staff.
Now it is
Pradeep sir, you're audible to
Pradeep,
the hall.
Now we are with you.
Hello. Hello.
Yes, Dr. Pradeep, you are online.
So what I have done after I have done a Gibbs procedure or a punch excision, I have irrigated the wound. Okay. Now I am going to put the fiber and I am going to ablate this tract. It is roughly 3.5 centimeter. I have already measured. So I am going to maximum deliver 350 joules. Okay. So in this case, the fiber is going in very easily, as you can see. इस तरफ आ जाइए. मुझे वो screen देखने दीजिए. हाँ. Yeah.
We can see
so
that.
you can see that the fiber is going in very easily. But suppose sometime the fiber doesn't go very easily. I'll show you one trick how to do that. You first put the probe inside. Over the probe you can railroad the tip of an infant feeding tube, bring it out like this, and then you can railroad the laser fiber on this. Okay, got it? Hello.
Yeah, we're listening.
Yeah.
We got it.
So now I am going to ablate the track. Okay. And this is a radial fiber. This is a new fiber, what is called as a corona infinite fiber. Okay. So camera की तरफ बताइए, corona infinite ring fiber. So if you can see that we have the corona fiber, we have the radial fiber where there is one ring, corona fiber has 2 rings, and now this new corona fiber has got 4 rings. What does that mean? That means that at 4 circles or 4 levels the laser energy would be delivered. So what is the advantage of that? The advantage is that the amount of skip areas which is left behind after a laser ablation will be on the lesser side. So now I am going to ablate the track. So I have kept the setting as 10 watts. I always use a continuous mode because again that is in an attempt to avoid a skip areas, and I am going to keep a watch on how much energy I am delivering. So my eyes would be on the machine. So I always keep the machine in front of me. Never keep the machine behind you. It should always be in front of you so that you can yourself keep a watch on the amount of energy delivered. Everybody should use a safety goggles, and once everything is ready, we put the machine on, put the machine on ready mode. So once he has put the machine on ready mode, I am going to release the lock on the foot pad, and now I am going to start delivering the energy. Keep a suction over here because fumes would come out from here. Keep the ice water ready. Okay, so now I am going to start delivering the energy. Okay. So we have gone up to 50. So go on moving the fiber. The fiber should not be stationary at any point. So how much we have delivered? 255. Okay, so it is well within the limits. Okay, it is not necessary that if it is 350 you have to deliver 350 only. It all depends on you. You try to, from your side, you try to ablate it well. Now there will be always an HR accumulation on the tip. So sister, take a piece of wet gauze with little hydrogen peroxide and clean it, and give me a scoop. I am going to now scrape this track. Now why do we scrape the track? Because we have burned the tissue. When you burn the tissue and HR is formed, this HR has to come out because this is a dead tissue. So whatever epithelialized tract, abscess cavity which I have burned, I am going to scrape it out. Sister, give me little saline also. I am going to flush it. Normal saline. No, cold saline, sorry, now cold saline. Okay, so now we are putting cold saline inside, so this will help to cool the tissue also. Scrape it. So this has to be scraped in all 360 direction in a circular manner.
Pradeep, earlier there was a question from the audio, somebody from Gangaram Hospital who said that they use a cautery instead of laser. You think that makes a difference?
Yeah, you can use a ball cautery, but you require you cannot use a normal cautery.
No, scope, with a scope they cauterize
yes,
the...
Yeah, with the WAF scope you can use a ball cautery. Ball cautery is better than a normal cautery. Have you cleaned the fiber?
So are the results different compared to laser?
I don't know. I don't have much experience with it, with the ball cautery. But I think it should work. It should work because probably, see, our aim is to ablate the tissue. Whether you ablate it with radio frequency, you ablate with laser, you ablate with cautery or any other energy mode, I don't think so it should make much of a difference. I think it should be the same. So now we are going to...
Yeah, you can ask.
Ablate again. Again put it on ready mode. It's ready. हाँ ठीक है. So I have 100, I can deliver 100 joules more.
Take the mic, please.
So earlier I had delivered 250, so I have about 100 joules more in my kitty. So I am going to use that 100 joules now for the second sitting. Okay, so everything ready? Yeah.
Is the mic working there?
Please kindly shift the audio to OT number 2.
How much?
So while Pradeep, while you fire this, we'll just go to the other OT. Okay?
Sir, what I was mentioning was for the ball, there is a ball cut tip which.
Professor, am I with you?
That's what he said. That's what he said.
With spray setting, it works very well. You have to put it like.
Array, curiosity look is very important.
Skip lesions are very less. In laser, we are not sure. It's not the vision. You're doing the laser, so you have to recheck with the scope after you have put the laser and thing.
No, but take now.
So we are back with you, Kamal, now. As we saw, you have ligated all the vessels that you could feel.
Yeah, Professor, am I with you now?
Yeah, I'm with you. Can you hear me, Kamal?
Yes, sir. Sir,
So
I have done all the ligations all around.
Ligating all the vessels.
All the ligations. Now I'm
ligated.
again going to insert 3 gauze pieces and gently bring them out. Now previously, if you remember, we had shown how the masses were coming out. Now there is no mucosal prolapse.
Okay.
So that
you
is
ligated the 11 o'clock hemorrhoids.
Yes, sir. All the 3 hemorrhoids plus additional ligation at 6 o'clock has been done. So now I will start with the laser hemorrhoidoplasty. Now whosoever is standing in the OT should be wearing the goggles. And I have got 2 fibers with me. One is a bare fiber and another is a conical. Both are good enough to be used. So the dosage is 6 watts. ये मेरी वाली स्पेक्स उतार लो आप पहले मेरी वाली उतार दो आराम से दोनों हाथों से
Hello sir. Sir, my name is Sukhdeep Singh from Punjab. Can I say, can we use fixation procedure like fistula in this type of short PNS?
So I think he has done that. He did that. He cored out that track with that fixation device. He did that. So basically that even that punch biopsy does that only. It cores out the track. But you could use it. Provided if you have a thin track, then you should have a thin size. The punch biopsy has got different sizes, so you have to adjust the size.
IMDSL.
Fixation device must be just one size. So if it's a small
Smith.
track, that may be too big also.